So what we do is, I wanted to just add on some questions have been done like the radiology one, so I won't spend too much time on those. Let's start. So there was a question from primary amenorrhea. I don't know the age of the girl, but the questions that were given, the scenario that was given was that breast was well developed, Tanner stage 4. There was no uterus and no ovary. That's the clue. No ovary means that the gonad is probably, so it's probably 46XY, and testosterone levels were normal male level. So then this is amongst the two. I don't know the other options, but when there is breast development with no uterus, you think of two things, MRKH or AIS. How do you differentiate based on karyotype or based on the gonad that is given? So if there's no ovary, it is complete AIS. Too many questions from OBG. That's very good, I think, in my opinion, because I think most of them, I think 95% were very, very doable. Okay, so she was a 14-year-old girl, all right. Okay. Okay, all right, fine. So then this was quite doable. Next question, a question this has been covered in radiology. I think two questions came from molar pregnancy. One was the image-based question on snowstorm appearance, where beta HCG was very high. I think the value was given more than 1 lakh. Correct me if I'm wrong. Okay, and apart from that, there was the image given the snowstorm classical. So this was complete mole. So then, okay, in the earlier question, there was scanty pubic and axillary hair. Fine, fine. That is, of course, AIS then. Okay, so what else was given in this question, and what was the other question on molar pregnancy? I think the other question on molar pregnancy, okay, this was 5 lakh. The other question was, I think, the treatment. So there were two questions. Correct me if I'm wrong. One was the image, and one was the treatment, where the correct answer, of course, is suction and evacuation. If there's anything, any other options, just fill me in. So what else? Probably one would have been methotrexate, I'm sure. Okay, I'll just add here scanty, pubic, and axillary hair. So I remember for the future. Suction curettage. Okay. Anything else was given in the option? Do let me know. I will check the messages later. This, of course, is the correct answer. Grape-like vesicles. Grape-like vesicles were seen here. Okay. DNC was given. Yeah, so there were two questions on molar pregnancy. So I think just fill me in. I'll keep checking the chat box. We'll move on. So two easy questions from molar. Molar is a very high yield area. This has been covered in under radiology. This is the string of pearls. There was a young girl with irregular cycles with ultrasound showing the typical string of pearls appearance. If you could just fill me in and the other options, then we can move along. Methotrexate we don't use in molar pregnancy. Methotrexate we use in choriocarcinoma. Molar pregnancy always is suction evacuation followed by beta HCG surveillance. There is a 15 to 20% chance she may develop choriocarcinoma. Choriocarcinoma, the treatment of choice is chemotherapy, that is methotrexate. Okay. So grape-like vessels was a different question. So that's what there are two questions and there's a lot of confusion. What was what? But I think both the answers are pretty clear. Okay. Now, this was an important question, so I'll just spend 2 minutes. And this has been discussed in the classes when I discuss management of twin pregnancy. I always show this and I always show this image. And I always tell that what is this? This maneuver is called internal podalic reversion plus total breech extraction. And the only which is transverse lie, and where an ECV or an EPV has failed. So obstetrics in today's day and age, first of all, is done always under general anesthesia. It's done in the second of twin with transverse lie. So if the second of twin is transverse lie, the first has delivered, the second is transverse lie. The first thing you try is ECV, external cephalic version, or external podalic version. But if these fail, then remember that clock is ticking. You don't have much time. Shift to OT, and under anesthesia, either do an IPV plus a total breech extraction, that is, grab the feet of the baby, turn the feet towards you, take the baby out. It sounds very easy. It's extremely difficult to do. Or you do a emergency cesarean section. So this is a question which has been asked for the first time, but I always teach this very important image-based question. Okay. The other option was okay. Okay. So yeah, lambda sign we will cover. I've got that question also. There's another question, right? I'm coming to that also. Okay, so this was delivery of a non-cephalic. It's actually a twin in the transverse slice. So a better answer if this was the option, delivery of transverse slice, second twin. Okay. Okay, we'll go one by one. Questions. I know you're writing the questions. There's a question on polyp with feeding vessel. I don't have that. I will add that. Okay. Okay, so this is a very commonly asked. This is asked in every exam. This is straight away Chadwick sign, bluish hue of the cervix and the vagina on examination seen in early pregnancy. So I'm not going to spend time here. Next question was a patient who has LNG IUS for contraception and she presents with irregular bleeding and asks for it to be removed. Right. So, but this was the question, or demands for it to be removed. Someone told me, what is the next best step? Should you remove it? Should you not remove it? Remember, one of the known complications of, well, I am moving fast. Don't worry, Pranay, I'm moving fast. One of the known complications of LNG-IUS, especially progesterone contraceptives, is irregular bleeding spotting. So all we have to do is reassure the patient. Most of them will become amenorrheic by the end of 1 year. Okay, so the other question options, just do let fill me in and I will see from the chat box. Okay, the next question was a question. Just correct me because I'm getting a lot of mixed reviews here. There was a question, a scenario was given on recurrent pregnancy loss in the second trimester with the ultrasound. There's an image with the cervical length shown. Somebody was telling me it was the placenta, but I think it was the cervical length which was shown. And what do we do here? What are we going to do here? The treatment, if the treatment option, if the treatment was asked, I don't know what was asked, the treatment, she's a perfect candidate for doing a cervical cerclage. Recurrent pregnancy losses, especially in the second trimester with a short cervix, you're going to do a cerclage. Anything else from here? Please tell me. Yeah, that stool wala question we will come to, don't worry. So yeah, so the question or the diagnosis was asked, not the management. So this is cervical insufficiency. Okay, so cervical insufficiency or incompetence. So the management was not asked, the diagnosis was asked. Fine. If the patient wants to remove, it's your job actually to explain to her, to reassure her, because this is a known complication. In fact, before putting the MENA, we always tell them expect irregular bleeding for up till a year. Okay, which of the following is a contraindication to methotrexate for unruptured ectopic pregnancy? And this is the correct answer. If cardiac activity is there, we never give methotrexate. And the other options, I think beta HCG, I need to know the value. And what were the other options? Was the size mentioned? And I think primary gravida was mentioned. So what are the other contraindications? Beta HCG, remember, we give it if it's more than 5,000, we will give methotrexate. Less than 5,000, we will not give. Okay. And anything else? Let me know, fill me in here. There's a bit of lag, that's why I'm just waiting for the answers to come on the live, and that's why it's taking a bit of time. To 2200 beta HCG. Okay, 5 centimeters. What was mentioned? 5 centimeters, 3 centimeters, because more than 3.5 we will operate, right? Okay. All right. It must have been three, 2004 to 2200, anything less than 5,000. Okay. And the fourth option, someone told me primary gravida. I'm not sure. But that is an easy question. Again, a very easy question. High blood pressure, which contraceptive will you not give? You will not, especially uncontrolled high blood pressure, you will never give an estrogen containing contraceptive. Very easy question. We will move on from this. The next question was a question on tubal sterilization. What is the best permanent sterilization method for a woman who doesn't want to have more kids? And the other options were quite weird. It was quite obvious that the answer is modified pomeroy's. This is what the government of India wants or advises. The other options, I think, was salpingectomy, salpingotomy, partial salpingectomy. I think that was there. So remember, if when do you do a salpingectomy for tubal ligation? If the patient has a failed pomeroy's, that means you've done a pomeroy's and then she conceives and she's like, I want an MTP now, your procedure failed. What do you do now? So you do the MTP and you will do now a salpingectomy or a partial salpingectomy because you don't want another failure to happen, right? So this is a modified pomeroy's. Okay. So this was what we do. Okay, right. All right. Next question, another question which is preconceptional patient is diabetic and her HbA1c is 8.5 and she's on insulin. She wants to get pregnant. What are you going to do? All right. So remember, you have to optimize the HbA1c. You have to bring it less than 6 because I've told you this, the higher the HbA1c at conception, the higher the risk of congenital anomalies. Right. In fact, with the HbA1c of 12, there is a 25% risk of anomalies. So you want to bring her sugars down. Okay. So you have to reduce her HbA1c, or I think one option was increase her insulin. Okay, reduce the HbA1c level, and then she has to conceive. What are the other options? One was start folic acid after conception. So actually, the best answer here would be start folic acid also. Reduce her HbA1c and start preconceptional folic acid, not folic acid after she conceives. You have to give her folic acid 3 months preconceptionally. All right, so this was an easy question again. Postmenopausal woman with a hot, flush, dry vagina. I think this was a question. I got again mixed options. Is this a question? Is this not a question? So please tell me if this was the question, then FSH and LH are going to be high. Okay, FSH and LH are going to be high and estrogen and progesterone are going to be low. Right. So if this was the question, let me know. I'm not too sure. I'll just wait for a minute because I'm not sure if this was a question. Yes, same question was there. All right, it's there. Fine. So this was quite easy. Again, postmenopausal estrogen will go down, progesterone go down. That's going to cause a positive feedback on FSH-LH. Then there was a question on late D cells. A few people told me they were variable, but majority said no, they were late. The dip was happening after the peak of the contraction, right? So if this is classically late deceleration, variable has no relation to the contraction, and early has a very symmetrical correlation. Okay. Okay, then there was a question, two questions in labor. I got one, I'm not sure about the other, but let's discuss this. There was a patient in labor, ARM was done, and there is sudden fetal bradycardia. What is the likely diagnosis? I think in this question, only head is 5 years palpable, or this was some other question. So sudden fetal bradycardia on doing an ARM is most likely to be, it could be abruption also, but abruption, they would have likely given bleeding happened. If there's bleeding present, it is more likely to be abruption. If there's no bleeding and the head is high, 5/5 means the head is high, almost floating, it's not entered. So there's a good likelihood that this is cord prolapse. Okay. Okay. All right. Okay. Same image from the workbook came of variable deceleration. Okay, let me see what other everyone else says. So that's what I'm saying. Some people are saying it was variable. Some people are saying it was 100% late deceleration. Okay, same question. This was there. All right. So what was option D? Option D, rupture. Uterine rupture is there. What was option D? Cord prolapse I have. All right. Okay. Then there was a question, there were two questions on gross post-hysterectomy uterine specimens. There was one question where there was a lot of confusion. Is it fibroid? Is it adenomyosis? But it was given a diffusely enlarged uterus was mentioned. I think they mentioned also that was 12-week size. Correct me again if I'm wrong. A Paris woman with heavy menstrual bleeding underwent a hysterectomy. This is the cut section of the uterus. It was a diffusely enlarged uterus. It is adenomyosis. Menorrhagia, heavy menstrual bleeding, plus dysmenorrhea, diffusely enlarged uterus. Okay, precipitate labor was there. Precipitate labor was there. Fine. Okay, so this is like I don't know. That's what I'm saying. I think it's adenomyosis. Some were saying it's fibroid. I think there was a separate question on endometrial cancer also. Okay, so diffusely enlarged fibroid there'll be a very well defined whitish colored lesion. If that's not there, they will both present similarly. Although adenomyosis is more likely in a Paris lady, fibroid is more likely in a nulliparous. 60 questions from OBG. I got only 30. Okay, let's continue. This is a INI repeat question. The same question came from INI November. If this is the same question, there's a pap smear which shows atypical glandular cells. Whenever glandular cells are there, you suspect an endocervical, that is glandular means columnar epithelium. So suspect an endocervical or an endometrial pathology. Endometrial cells might have dropped down from the endometrium. So always do not only a cervical biopsy, but also an endometrial biopsy whenever you have glandular cell abnormality, which are very rare. We mostly see squamous cell abnormalities. So if you see glandular cell abnormalities, you have to take an endocervical and an endometrial biopsy. Okay. Okay. Then there's a question, very easy question. Curdy white, vaginal discharge, pruritus, non-foul smelling. You will see pseudohyphae. This is nothing but candidiasis. What will you see? Pseudohyphae and budding yeast cells. Right. Okay, again, easy question. Anemia Mukt Bharat treatment. This is not prophylaxis. This is treatment of anemia. You give double the dose. Prophylaxis, we give one tablet of 60 milligram iron. This is, sorry, my typo, 500 microgram of folic acid twice a day. So you're going to double the dose. Once a day for prophylaxis, twice a day for treatment. I'm going fast, Vijay. This is, I think, quite fast. Okay, I'm only stopping on where I have some confusion कि कोई question में doubt तो नहीं है. Clinical scenario on rectal endometriosis. There was a question whether the patient is bleeding, having cyclical bleeding per rectum. Whenever you have bleeding from anywhere in the body, which is happening only during periods, it is always endometriosis. This is rectal. She probably has a rectal nodule which is felt, or this is called as rectal endometriosis. Bleeding during periods. Some women have bladder endometriosis. They are going to have cyclical hematuria. Cyclical bleeding PR is endometriosis, nothing else. Okay, now this is a question which I'm a bit confused on this. You have to help me out. There's a patient in labor. What was her dilatation? I want to know. Okay, some were saying 6 centimeters, some were saying 4 centimeters, and the anterior fontanelle and posterior fontanelle both are palpable. When both are palpable, what does that mean? The head is deflexed. It is not flexed. In flexed head, you won't feel the anterior fontanelle. Only when the head is straight, like how I'm teaching you, anterior, posterior, you'll be able to feel both. So this is a deflexed head. Now, deflexed head kahan hota hai? Remember, deflection is always associated with occipito-posterior. Right? Occipito-posterior, you commonly see fully dilated or 6 centimeters, 6 centimeters dilated. All right. And I think the station was also given 0 station. Okay. So this is not face, this is not bro, where this is occipito-posterior is what I understand. Transverse, so deep transverse arrest was an option. If it was, remember DTA is defined when the cervix is fully dilated and the cervical suture will be in the transverse diameter. Here it was given the oblique diameter. So this is more likely to be occipito posterior. All right, station at 0. Okay, fine. So station was 0 station, but 6 centimeters dilated. 8 hours से labor में थी, 8 hours labor. So going into prolonged labor, one of the causes is occipito-posterior. Postmenopausal bleeding with an ET of 8 millimeter, was this a question or was there an image that endometrial CA, was that the image? There was an image and this question, both only one question. So I think OBG was very interesting. A lot of different, I mean, a lot of PYTs, of course, but nicely in a different way they had asked. So, but it wasn't that difficult. It was a long question. I know all the questions are usually made long. This was the question. So you'll do an endometrial biopsy. Anything more than 5 mm, no image. Okay. Anything more than 5 mm, you will do a biopsy. This is a repeat question. This has been discussed. This is lambda sign, DCDA, not wasting time on this at all. A woman gives birth to a stillborn baby. What is given for lactation suppression? Again, easy question. Bromocriptine or cabergoline you're going to give for lactation suppression. Right. Now, was this a question? This is again, if this was the question, then this is again a previous NEET PG question. Someone told me there were two specimens of the uterus. One was adenomyosis, one was endometrial CA. There was some growth seen inside the uterine cavity. And if this was the image, the irregular growth seen in the cavity, then it is endometrial carcinoma. And someone was telling me there was a question on polyp with a single feeding vessel also, right? Was this the same question and was it a polyp or was it endometrial cancer or were they two separate questions? Okay, this was the question, endometrial cancer. So this is NEET PG, previous NEET PG repeat questions. You got questions from INI, from NEET PG, exact same to same repeat. Polyp alag tha fir? Polyp was separate? And this was one question I found. I think it was very interesting. Did this come? Does anyone tell me, did this actually come? Okay, so it was a separate question. Polyp was separate. Obese multipara with polyhydramnios कौन सा question था? Polyp was different, ठीक है. So in India, pregnant women do not eat which fruit because so papaya नहीं खाते. ऐसा नहीं है मना है. क्यों नहीं खाते papaya? Because in olden days, like olden means really olden days, raw papaya, the seeds of raw papaya are known to be an abortifacient, है ना? तो वो अब ना it's gone all along. If you have a nice ripe papaya, nothing is gonna happen. But वो fear is so much now. Na even I say if the patient comes to me कि नहीं it's okay, don't eat papaya. You nothing will happen for 3 months if you don't eat papaya, or 9 months also. Okay. So, so this is a PSM question. Okay, it's a gynae question also because this is commonly asked. All right. So I think that is what I have. I'll add the polyp question. Anything else? You all have my number or put on the chat box. Please let me know. And all the best for your result.